Good afternoon, everyone. My name is Dr. Maxwell Abraham, and I'm an orthodontist at Abraham Orthodontics in Leamington, Ontario. Um, I am so happy that you guys joined us today. I see a lot of familiar faces that were with us the first time around, and I see quite a bit of new faces. People, within dentistry, outside of dentistry, and physio, massage therapy, and chiro. So it's really nice to have this interdisciplinary group with us today. Our topic that we have really came from our survey that we put out the last time around, and there was a lot of interest in having a physiotherapist perspective on TMD and just the kind of ways that they could really support our teams in treating these patients. And Corey just has such a vast amount of knowledge and experience in this. And she has a really, really excellent webinar for you guys today that I'm really proud to host. Before we do that, just a little bit of housekeeping again. So we have our YouTube comment section that's here on the side or on the bottom of the screen for some of you guys. Again, please, right now, feel free to write your name, the practice where you're from, and this way we could all better acquaint ourselves with each other. And we're also going to use that medium to answer any questions that you may have. So please, as the webinar goes on, write any questions that you want, and Corey's going to go ahead and answer those for you. And then just a little bit of background on myself. So for those that weren't here last time, again, I've been an orthodontist for about 4 years out of our startup practice in Leamington. And, it's just been so incredible to see the kind of impact that we can have on people's lives in so many ways. And, our previous lecture that we had really has been our community PSA for a very long time. And it's been that, we want to see patients to be screened for orthodontic treatment by 7 years old. Now, majority of the patients are not going to be getting any treatment at this age, but really a lot of it's for anticipatory guidance, screening for very specific problems, and giving just the family a really good idea of where things are headed for their children. And this is a service that we obviously do for free, and we follow up with these patients every 6 months to a year, also at no charge, until it is the perfect time to treat, if it's even still needed. And the things that we're really looking for at this age mainly just consist of a posterior crossbite. So it's when the top teeth sit on the inside of the bottom ones, as well as an anterior crossbite. So again, if there's anything that I would be the take home from that webinar, would be that to identify those two things in young patients, refer them to an orthodontist, and those are things that if we don't treat them at an early age, it can lead to surgery being the only option later on. Other things that are important at that age also are open bites, where the top and bottom teeth don't even really connect, as well as any obvious early loss of baby teeth or primary teeth, or impacted permanent teeth. So the full webinar that we presented last time is in the comment section, as well as the link is also provided in your invite for this seminar. So that's going to be saved for you guys to access. And also I want you just to keep note that this webinar that we're doing today will also be able to be replayed. So if you have any colleagues that you knew or that you feel would benefit from this, you will be sent the link shortly after, in order for them to rewatch it, or even for yourself. There's a lot of good information that's going to be in here, and sometimes it's hard to get it the first time around. So feel free to go back, rewind, revisit it, and once things get back to normal, we could really apply what we're learning into all of our respective practices. Just before we get started, there's a video about our practice, and really just everything that we've done and everything that we just represent, that I just want to share with you guys to give you a better idea of just who we are. And right after that, we will get everything started. We opened the practice 3 years ago. In that short time, it's just been so incredible to see how much someone's smile transformation can make on their lives, really at any age, from 7 to our wisest patient at 77. A lot of patients, when they start, they may not smile a lot, or they might not like to show their teeth, and they don't even realize it. And then there's this little switch where they just light up. It's that change in confidence, that change in self-worth, and it makes a difference in people's lives, and it's incredible for us to be a part of. We try to remove as many barriers as we can to really open the door for the families to make the best decision that they can. And it's simple things like flat fees, free exams. Our monthly payment plans are customized to the families. We don't even run credit checks. And I think that's why we've been able to really connect with our patients on so many different levels. We started off so focused on creating these beautiful smiles and doing excellent work to really now realizing that it's our work in our community that sits at the heart of who we are. And ultimately, it has become really the core of our practice at Abraham Orthodontics, and it's really what drives us today and what will be driving us for many generations to come. Alrighty, so just a little bit of background. Corey Ireland has been a manual physiotherapist working out of Kingsville for a very long time. A couple years ago, she opened up her own practice, strictly focusing on manual physiotherapy. And not being from that field, it can be sometimes confusing of what the difference is between different physiotherapists. And I think we all can appreciate that everybody really finds their niche of what they like to do, and what kind of patients that they generally feel the most excited about treating. And Corey's field, she's one of the very few that have full training for the full body in manual physiotherapy. There's a couple other excellent physiotherapists that have done manual physiotherapy training of just the jaw joint, but Corey does it all. And she has been such an excellent service to many dentists in the community in really collaborating and helping treat their patients that have a whole wide array of TMD symptoms. So her webinar that she's doing is really just focusing on the different types of TMD that can present, and really where does physiotherapy fit in it, whether it's with a splint, without a splint, any type of at-home care. And I think this could help better equip us to feel a lot more comfortable in seeing these patients in our own practice and helping them find real solutions to really help their symptoms. I think gone are the days of jumping to any type of surgical treatments or things that are very invasive. And, there is a lot of positive research towards physiotherapy modalities in alleviating a lot of the symptoms. And I know many of us here anecdotally know that it really does make a big difference when you pair it up with any type of in-office treatments. So without further ado, I'm going to pass this over to Corey. And again, if you guys have any questions during the webinar, please write them up in the comments. Corey will also be on there answering them as she goes along. And again, I thank you guys for coming in. I hope you've all just been healthy and safe. And I'm really, really looking forward to seeing everybody in person and getting things back to normal.
Hi everyone, my name is Corey. I'm a CAMP certified physiotherapist in Kingsville, Ontario. COVID and the necessary social distancing has created this platform for almost endless webinar content. Thanks for choosing to have a listen on a physio's perspective on TMD. It's my goal to make this valuable for you. But first, just a little about me. Born and raised in Essex County, I'm a county girl at heart, wine and human mama, wannabe runner, and joy seeker. I'm a nerd when it comes to thirsting for knowledge, information, and progressing my skill set as an orthopedic and pelvic health therapist. I mentor other physios to become leaders and experts and speak about all things related to physiotherapy and joyful movement. I'm big on language, not in the academia sense per se, but in the message and meaning it conveys. This is an evolving practice on my part, and I know it's innocent, I have to hold myself back every single time from correcting my clients when they say they have TMJ. Who's with me? In my practice, I often have people referred to me that have been seen by other allied healthcare professionals with little success. These people often have characteristics of persistent pain and complex symptom profiles. Due to the nature of both the presentation and the client, and their similarities with persisting pain and orthopedic complexities, it happened by accident that I ended up with a special interest in helping people with TMJ dysfunction. I'm preaching to the choir about the importance of oral hygiene, and as you know, limitations in opening can directly interfere with our patient's oral health and preventative care. But TMJ dysfunction has a direct and indirect effect on overall health as well. When we can correctly identify and intervene earlier, we can play an important and fulfilling role in our patient's quality of life. Because of the complexities of TMD, the joint itself, and the surrounding structures, it can be challenging to correctly identify the right patient who requires intervention. There is no gold standard for arriving at a diagnosis of TMD currently. Making it confusing is that people can have signs or even symptoms, but not actually have a temporal mandibular disorder. Research reports that 40 to 75% of the population have a sign of TMD, and of these people, 33% have one symptom. 50% of asymptomatic people have joint noise and deviation. This is me. At every single appointment I have with my dentist, he goes through his jaw, lymph, and MSK exam, and every time after hearing my click and seeing my mandible deviate, he is prompted to ask his TMD screening questions. But I don't have TMD, and he leaves it alone. And I'm okay. We'll add it to the list of things that make me me. But of the 5% of people that do have occlusional changes and decreased opening, and the 7% with severe dysfunction that are prompted to seek out help, TMD can be devastating. So, if signs and symptoms are common in the general population, when do we know signs and symptoms matter enough to require intervention? There are obvious consequences of a false negative when you miss the boat with someone that would require care, but there are also consequences of a false positive, especially because of the personality profile that is associated with TMD. Telling the right person who has signs and symptoms, but not actually temporomandibular dysfunction, will almost guarantee that they will end up with myofascial TMD down the road. This general principle is supported in pain science research, and in my own clinical practice, I have successfully treated and freed individuals of their chronic jaw pain who came to me on day one and said, 10 or 15 years ago, so-and-so told me I would have TMJ. Taking a good history that is followed through with an objective exam that is always in the context of the patient in front of you will allow you to appropriately reason through this. Knowing the general profile of patients with TMD can be helpful. 20 to 50-year-olds are most likely to report TMD, and there's equal prevalence of TMD in 15 to 40-year-olds, with the prevalence decreasing after 40. I have my own unsubstantiated theories on this. It's easier to help people who are asking for it, but we need to be aware of those who aren't asking. The research shows that men aren't asking or seeking care as often as women. For those individuals that go on to develop jaw dysfunction that interferes with their quality of life, there is a recurring theme of factors contributing to causation or persistence, and it's stress, dental signs and symptoms, and postural problems. The potential involvement of many components makes it challenging to both diagnose and treat TMD. So let's explore that further. There are physiological and behavioral consequences of stress that can play a role in TMD. People that are stressed out often engage in self-soothing behaviors that can be quite detrimental to both managing stress and their health. Cortisol gets a bad rap, but it's a hormone that plays an important role in achieving homeostasis. It's only when it's persisting in high levels as a result of continued physiological stressors that it can become counterproductive, impede healing, and promote tissue sensitization. Tissue sensitization is the result of a chronically overloaded autonomic nervous system, where balance lacks between our rest and digest parasympathetic system and our fight, flight, fright sympathetic nervous system. When your patient is in this mama bear alarm state, their threshold for tolerating inputs is markedly lowered. Things that shouldn't be painful are, things that should elicit discomfort will nearly cause them to keel over. These patients often have unexplained reasons for their TMD. On various ends of the spectrum, it's my clinical observation that these people with ramped up sympathetic nervous systems are far too often your grinders. Who wants to partner with me to do a study on this? Seriously. On the flip side, though, maladaptive behaviors and unoptimized physiology can further create and perpetuate stress, and a vicious cycle of chicken or egg ensues. Financial concerns, unsatisfying relationships, work stress, being spread too thin, or simply poor coping strategies for stress, coupled with an unhealthy lifestyle that lacks emotional support, has insufficient exercise, inadequate diet, non-restorative sleep, and a lack of fun and downtime, almost time and time again comes up in the history. As soon as my client addresses their stress and lifestyle in a more productive and healthy way, they become so much better at managing their pain, if not simply become better. The literature supports anxiety, depression, memory loss, and reduced concentration as traits that are common among those with TMD. If your patients aren't binging like Tina Fey in front of you or looking like Rachel during their appointment, it can be hard to identify. Using outcome measures to identify those qualities can be quite instrumental in recommending helpful interventions to your patients, and even knowing how to tailor and customize your interactions with them. Occlusal adjustment, appliances, orthodontics, dentures, periodontics, missing posterior teeth, and reconstruction can also play a role in a client's journey with TMD. When there is a gross loss of distal teeth, as in the case with arthrogenous malocclusion, there is an overcontraction of elevator muscles because they have to work through a greater range than what they are used to. This increased excursion to occlusion stretches the capsule and ligaments of the jaw beyond their physiological limit. Without good soft tissue support, the disc and TMJ complex is now abnormally loaded and degeneration ensues. However, when the front teeth are occluding first, the elevator muscles are now working overtime to achieve occlusion. This can result in painful trigger points in the masseter, temporalis, and lateral pterygoid. Less often, hypertonicity of pterygoid and hyoid muscles can actually result in an anterior disc displacement in the end. Dr. Mariano Roccabato is a physiotherapist and professor at the Dental School of the University of Chile. He has proposed this postural model as causation for TMJ dysfunction. He believes that a cascade is set off from habitually positioning the neck in upper cervical extension, such as in a chin poking position, and lower cervical flexion, which leads to shortening of the deep neck extensors at the back of the skull and the sternocleidomastoid of the anterior lateral neck. This results in the shoulder girdle elevating and rotating forward. This, in result, elastically loads the hyoids and alters the rest position of the jaw, hyoid, and tongue. Tightness in the throat can ensue and progress to difficulty swallowing. An elevated and retruded condyle is evidence that the mandible is now pulled down and back in relation to the maxilla, which results in altered occlusion. It's typically at this point that we see increased descending drive from the beginnings of tissue sensitization. Muscle bracing and spasm become prominent, and we have unfortunately arrived at the destination of TMJ dysfunction and pain. So now that we understand the who and the why a bit better, let's have a look at the signs and the symptoms. Clicking, popping, and grating can be par for the course, as is joint line pain and impaired opening, but that's just the tip of the iceberg. Ringing and ear stuffiness, dizziness, ear infection, and loss of hearing acuity can be associated symptoms. Neck and face pain and sensitivity to touch, cervical stiffness, headaches, eye discomfort and pain, light sensitivity, as well as the ear symptoms we just mentioned, can all indicate that the upper neck needs to be assessed as a potential driver of the presentation. Difficulty swallowing, throat pain in the absence of infection, voice irregularities, and frequent coughing or clearing of the throat due to alterations in hyoid muscle tension can also present as a result of the change in surrounding musculature. Pins and needles or even numbness can be felt in the face, palate, gum, tongue due to the trigeminal nerve. Restricted mobility, pain, or even limitation in talking, an inability to open smoothly, asymmetrical opening, locking, an inability to find their bite, bruxism, and looseness or soreness of the back teeth can be more obvious signs as well. With all this myriad of potential signs and symptoms, TMD typically falls into intra- or extra-articular categories. Disc displacement or internal derangement accounts for about 31% of all diagnoses. Chronically, this can lead to osteoarthritis, which accounts for 39% of TMD cases. Age and masticatory load are the main contributing factors for arthrosis. The remaining 30% are extra-articular presentations that can be described as myalgia or myofascial pain disorder. And this is where physiotherapy can really thrive to help with your patients in your own practice. Whether TMD is due to intra or extra-articular causes, there can be noise. We can all agree that crepitus that is either fine or coarse indicates that the disc is degrading, unfortunately. But what about that click? We can get valuable information depending if it occurs with the open or close, if it's reproducible or reciprocal. Having said that, we also need to keep in mind that clicking can also simply be muscular or ligamentous, and in the otherwise asymptomatic population, it might not necessarily indicate a need for treatment. Joint hypermobility, abnormal tension in the connective tissue, disc tear, pressure or lubricant changes with movement, or changes in the joint surface can also be the cause of clicking with jaw opening. On closing, clicks can be the jaw subluxing due to hypermobility, due to a tear of the posterior meniscal ligament, or a disc derangement. If the patient in front of you has an internal derangement with reduction, your exam will reveal a reciprocal click or popping with opening and closing without any coarse crepitus. You'll be able to passively stretch the joint at least 35 millimeters, and typically this isn't associated with any articular changes on tomography. Because the articular disc offers congruency and separates the superior and inferior surfaces of the TMJ, when it displaces, the condyles increase their chance of rubbing together, and this can lead to joint changes over time. With injury to the disc, we can get a snapping with movement. The first snap with opening is a reduction of the dislocation, and this is the joint recapturing the disc, achieving congruency again. The earlier the click means the lesser amount of anterior displacement of the disc, and it's an earlier sign of joint reduction, meaning a better prognosis. And that's exciting for everybody. With closing, there's another snap or click, and this is actually the joint subluxing and losing its congruency. The type of noise can be valuable in understanding the underlying cause. Frequent and involuntary joint popping may indicate a loose or a stiff joint, and cracking or clunking can indicate instability. Which brings us to mandibular gait. The pattern of opening matters too. The capsular pattern of restriction of the TMJ is ipsilateral deviation that prevents functional opening. When your patient opens their jaw and the mandible deviates to the sore side, and there's a lack of opening, this can indicate an arthrosis or articular change. With any mechanical obstruction, the deviation or deflection is generally in the direction of the involved joint as well. When the mandible deflects, this can indicate a dislocation without reduction, capsular adhesion, or joint ankylosis. Significant muscle hypertonicity can also be the driver. Depending on which muscles are involved will depend on the direction of the deflection. Muscular causes of deviation typically present as these large, inconsistent, sweeping alterations in mandibular gait, like as in an S or Z pattern, that are often not associated with clicking sounds. If clicking is present, and this is the case, this just may implicate poor coordination of the lateral pterygoid muscle bellies. To assist in your clinical reasoning, after observing your patient's active and typical mandibular gait, challenge the movement by gently guiding the mandible to follow a normal course of excursion. Feeling the direction and amount of resistance can help indicate the tissues involved. The softer the resistance offered by the tissues, the more likely the involvement is muscular, whereas harder resistance may indicate disc involvement. On the more involved side of things, we have our open and closed lock scenarios. A closed lock is typically initially an acute condition where the disc suddenly displaces anteriorly or anterior-inferiorly, and the condyle can't roll underneath the disc to start its anterior transitory glide. Muscular incoordination, asymmetrical disc movement, hypermobility, joint adhesions, degenerative changes, and alterations in joint hydraulics can be driving factors. You will find with this patient that opening is severely limited and it's associated with a hard or spasm end feel. Deviation or lateral intrusion to the opposite side is also limited. Acutely, as in an internal derangement without reduction, your patient will typically describe a history of limited jaw motion. Upon examining them, you'll probably notice that there's no reciprocal click and no coarse crepitus with opening. Their voluntary opening is typically less than 35 millimeters, and you can't passively stretch them more than 40 millimeters into opening. Deviation away from the sore side is less than 7 millimeters actively, and there isn't an S-curve deviation with the active open and close because the joint can't correct itself. Tomography would likely show a decreased translation of the ipsilateral condyle. This can also be representative of a traumatic arthritic presentation. When an internal derangement without reduction is chronic, your patient will report a history of TMJ noise. Your exam won't reveal a reciprocal click, but you may find coarse crepitus of the joint. While an open lock isn't as rare as the Champagne Gate scandal, it is far more painful, despite what Kelsey from Pilot Pete's season of The Bachelor would have you believe. On the more professional side of things, it occurs with forced opening, and the mandible is unable to close because the disc and condyle come off the temporal surface. It is best managed with manual distraction techniques, followed by splinting and care for a hypermobile joint. I have never personally seen an open lock in my practice. Although physios have been given guidelines with how to manage this in conjunction with the oral health care team, from my colleagues' perspective, this is quite well managed by splinting by oral health care providers. Which brings us to the topic of splinting. Understanding what the signs and symptoms are telling you in the context of the dysfunction and lifestyle of your client will be absolutely invaluable in deciding how to proceed next for them. It's my understanding that oral splints are often primarily intended to reduce sleep bruxism or reduce TMD symptoms. In some oral health practices, splinting is the primary management approach to TMD. Despite an initial decrease in muscular activity, the effects of splint usage unfortunately appear both transient and insufficiently strong to reduce sleep bruxism. There just isn't enough evidence right now, either in favor of or against, to provide a framework for deciding to use splints. Additionally, a splint can put the patient in craniovertebral extension. If upper cervical factors are ultimately driving the TMD, this compounding factor needs to be considered. Additionally, if bruxism is creating an imbalance in muscle tension and length and is the result of a stressful lifestyle, the effect of a splint can be particularly enhanced with physiotherapy intervention. Using your clinical reasoning on a case-by-case basis is necessary to make the best decisions for your patient. And maybe choosing to use the splint may be limited to the topic of protecting the structural integrity of the teeth, which obviously has an understated value for long-term care. But when you want to manage TMD symptoms best, targeting the entire upper quadrant and treating the person as a whole will achieve the best outcomes for TMJ health. In the extremes, though, as with cases of ankylosis, inflammatory arthritis or infection, disc perforation or displacement, or severe osteoarthritis, referring on to a specialist is absolutely necessary. In many cases, hygienists, dentists, orthodontists, prosthodontists, ENT, speech dietitians, counselors or psychologists, massage therapists, and physiotherapists can all work together to help our shared patient achieve their highest potential for recovery. Asking the right questions in a detailed intra and extraoral exam will allow you to rule in or out TMD and identify it early as well, to be able to decide who your patient needs on their bench and at what point in their journey. This is a critical strategy in TMD cases of insidious onset. I regularly use the Depression, Anxiety, and Stress Score, as well as the Central Sensitization Inventory at assessment and at 4 to 6 week intervals during treatment to identify those psychological and social factors that contribute and perpetuate TMD. The results from these outcome measures also help me guide the language and tone I am using when talking to the patient about their symptoms and prognosis. Even though you can see what their bite is doing, asking your patient if it feels recently unusual or uncomfortable, or even if they think they can achieve a symmetrical and effective bite is helpful information. Ask them where their tongue typically rests. So many of my patients, actually most, aren't aware of what their tongue is doing in their mouth. Find out about their diet, sleep position, preferred rest positions, about chewing gum, smoking, nail biting, grinding, and clenching. What is their stress? What is the 24-hour pattern of their symptoms? What makes it better? Do they exercise? How does this impact their quality of life or even their occupation? Inquire about headaches and neck pain, as well as a family history of connective tissue and joint disorders. It takes time, but it's all helpful. On the positive end of the spectrum, 40% of clients will have their symptoms spontaneous resolve. However, without treatment, clients with associated symptoms of clicking and locking can take 4 years to resolve without treatment. Clicks and pops that are unpredictable require more aggressive intervention, and conservative care on its own won't be enough. The more repetitive and non-modifiable the deviation pattern is, the more likely the disc is adhesively restricted and morphologically altered. Additionally, a history of significant jaw trauma, protracted signs and symptoms, or a very limited range of motion signal probable joint pathology and a guarded prognosis for conservative care. Co-treatment with a specialist is recommended in the literature. Upon the initial exam, when a temporary correction of mandibular gait or reduction in symptoms can be achieved, this can indicate a better prognosis for conservative care. Overall, 85 to 90% of TMD cases can be treated successfully without surgery, with 8 to 12 months of conservative treatment with a focus on physio. Treating TMD takes time. Putting this time frame in a realistic but positive light will also be helpful in reducing the chance of ongoing persistence. We always need to consider the patient's pain-related disability and psychological status and attend to this appropriately. Remembering that chronic pain severity, depression, and sensitization all play an integral role in actual and perceived jaw disability and overall worse outcomes is helpful in directing our approach. Physiotherapy can be quite effective at reducing pain and inflammation of the TMJ and to improve TMJ function, especially in cases of myofascial TMD. Those patients with TMJ symptoms but lack local findings, closed locks, as well as mild and moderate internal derangements. Being in pain or having persisting injury in other places for chronic periods of time affects our hormonal balance that can be counterproductive to healing and pain management. And addressing this will improve overall results of the intervention. As you can see from this picture, the jaw is surrounded and influenced by so many muscles. Anxiety, poor sleep, and other suboptimal lifestyle habits, along with cervical dysfunction, will perpetuate abnormal muscle tension. Masseter, temporalis, pterygoids, hyoids, buccinator, platysmus, as well as anterior, lateral, and posterior neck, and the shoulder girdle muscles need to be assessed as potential drivers. Physio is quite effective at altering muscle tension with strength and improving muscular endurance, which can make a world of difference in a muscle's ability to relax and oxygenate. If it is difficult to identify if the muscular system is at fault, we can differentiate by reasoning through our findings. Myofascial causes of TMD can be ruled in when opening is only limited at the end of motion and presents asymmetrically, but protrusion is full and symmetrical. Additionally, when there are large inconsistent sweeping alterations in mandibular gait that aren't associated with clicking sounds, this also implicates the muscular system. However, as we mentioned earlier, if there is some clicking, this is just poor coordination of the pterygoid muscle bellies. Distraction or compression of the joint can help isolate possible pain generators. If you have your patient unilaterally clench on a cotton roll or rolled up exam glove, this will distract the ipsilateral joint and compress the contralateral one. If the pain is from a muscle that closes the mouth, it may be reproduced regardless of the side the cotton roll is on because the muscle will be under active tension. Upper cervical dysfunction can play a role in perpetuating signs of TMD but can also create symptoms that mimic TMD. And physios can be very helpful to your patients in helping to reduce their TMJ complaints in this case. The function of the TMJ is inherently linked to the biomechanical function of the neck. There is shared neurology, and from a mechanical perspective, the position of the upper cervical spine influences the position of the mandible. Having a forward head posture affects both the balance of muscle tension as well as how the mandible rests. Neck problems that involve the upper cervical nerve roots of C1, 2, and 3 have the ability to influence the motor nerves that control the muscles that cross the TMJ. The trigeminal cervical nucleus can make it challenging to identify the jaw as the victim or the culprit. Because the sensory nerve fibers in the trigeminal nerve interact with the sensory fibers from the upper cervical nerve roots. I had a young gentleman referred to me by a local dentist. He had unilateral jaw pain, fullness and ringing in his ear on one side more than the other, and light sensitivity. Over a 6-month period, he tried to manage it on his own, and he finally sought the help of his dentist. Based on his dentist's exam, his TMJ was cleared, and his dentist suggested that he come see me. After only just 2 treatments aimed at improving the mechanics of his C1-2 joint, 90% of his symptoms had resolved. I wish all cases of TMJ pain were this easy, and unfortunately this gentleman doesn't constitute the majority of what I see, but it points to the importance of ensuring the neck is mechanically operating well. It can be challenging to treat TMD well in physiotherapy because there are too few published studies out there and way more research is needed before we can establish protocols for management efficacy. As a result, managing TMD right now requires a mixture of both art and science. Physiotherapists trained in treating TMD are choosing therapeutic interventions based on the relevance to the patient-centered findings that can be monitored over time for relative change. We are also good at managing variables related to chronic pain such as hyperalgesia and allodynia. As an internationally recognized CAMP-certified manual therapist, I have a complex understanding of multiple systems, including how those systems work independently and collectively as a group. The precision required to identify and correct the problem within a system is improved with the application of highly skilled hands-on assessment and treatment. This advanced training includes the ins and outs of the arthrokinematics and biomechanics of the TMJ, which is not something that is covered in much depth in entry-level physiotherapy programs. I also have a comprehensive understanding of pain science. I'm trained in acupuncture and certified in integrated dry needling. In my practice, I believe in a one-on-one model with only the physiotherapist providing the care. This allows for rapport development, time to truly understand the breadth and depth of the issue, and expert treatment delivery. Manual therapy, dry needling, acupuncture, heat, therapeutic ultrasound, and taping are interventions that I use for my patients with TMD. But the biggest piece of the pie is lifestyle management, education, and exercise in the context of the patient in front of me. At the center of TMD management is individualized education. Empowering our clients with information about the nature of the disorder, including drivers and victims, prognosis, and available treatments, is invaluable. Spending time sharing information is especially helpful to get clients on board with their plan of care as well as alleviating their helplessness, which doubles down to downregulate the sympathetic nervous system and decrease tissue sensitization. I am very careful and deliberate about language in all of my conversations with patients, but especially when it comes to explaining my findings and providing recommendations for change. I understand the importance of managing expectations, but in my experience from what my patients have shared with me, they will hang on to certain words forever, and this can really set the stage for central sensitization. I'm pretty good at recognizing those individuals who have or are at risk of sensitization, but there are some really good fakers out there. So even though I'm adapting the style of my delivery to build rapport with the patient, I still err on the side of caution with the types of statements and words I'm using. For my patients dealing with persisting concerns with TMD, giving them some pain science 101 is also quite empowering to understand the mechanisms behind chronicity. I feel like we are all on the same page about bruxism. If only we could get our patients to stop grinding their teeth, their oral health status would be so much better. Knowing that this is an involuntary response to stress in a sympathetic system in overdrive, if we want our patients to ultimately reduce grinding, they need to downregulate their sympathetic nervous system. This is complicated and multifactorial, but completely in the realm of possibility. Advice and recommendations for quality sleep, good nutrition, and regular physical activity is paramount. Patients need to be made aware of the potential role of their emotional and mental distress on their symptoms and encouraged to seek out the necessary support. Additionally, letting our patients know the potentially negative role of biting on objects, singing, using musical instruments, phone use, sleep posture, and so on is the first step to behavioral change. We need to be aware and understand first. To reduce accessory muscle use and to encourage a normal resting position of the mandible, it's helpful to give patients tips on how to limit mouth breathing and breathe with their diaphragm. Those with hypermobility, especially with mouth opening, may require education to avoid these end-range positions. Teaching patients not to open farther than the position that permits the tip of their tongue to maintain contact with the hard palate just posterior to the upper incisors can be quite helpful to settle acute capsular ligamentous strain or to help to prevent uncontrolled movement. I frequently tell my clients, just because they can doesn't mean that they should. Oftentimes, recommendations are made about food consistency, laterality of chewing, and postures to eat in. Letting patients know that harder and drier foods require an increased amount of chewing cycles and longer times in the mouth before swallowing can be helpful in their pain management. I could spend hours chatting with my clients, sharing unique recommendations and guidance with them, especially in those hard-to-treat cases. The majority of people want to understand and want to have tools to help themselves, and education is the best medium for that. But to help them along, we can use our hands too. Soft tissue techniques have an important role in the management of patients with TMD because of its relevance to all TMD diagnostic classifications. I use dry needling, cupping, deep tendon frictions, and soft tissue mobilization to help reduce muscle tension and improve extensibility. Friction massage is helpful to stimulate fibroblasts and other connective tissue components, which is especially beneficial for symptoms at joint line, retrodiscal space, temporalis insertion and coronoid process, and over trigger points, particularly in the temporalis. Dry needling uses the same type of needle used in acupuncture and is inserted into the trigger point of the muscle to get it to release. It's particularly helpful to release tension in the masseter, neck, and shoulder muscles for those with TMD. There are lots of manual therapy techniques that can be especially helpful with improving joint mechanics. Intraoral mobilization, such as jaw distraction, anterior glide with pre-positioned mouth opening, medial and lateral glides, cam glides where you're going down, forward, and in, and these cam glides with pre-positioned mouth opening can all be so helpful to reduce pain and improve function. In addition to improving joint motion, manual therapy can decrease spinal excitability of nociceptive pathways, indicating a downregulation of central sensitization. To follow up, self-mobilization can then be a useful part of their comprehensive home program to assist with carryover and promote independence. Patients are instructed to maintain freeway space and how to direct their force so they can do this effectively. The most commonly known exercise routine for TMD is Rockaboto's 6x6. He uses 6 exercises that are to be done 6 times per day. Although it is widely used, like so much of the assessment and management of TMD, it is minimally studied for effectiveness. I have received numerous funny looks when I ask people, "Where is your tongue in your mouth?" Positioning the tongue in its rest position to allow it to rest, relax the jaw muscles, and promote diaphragmatic breathing is the first on Rockaboto's list. You wouldn't believe how foreign and awkward it is for some people to place the anterior third of their tongue at the palate with mild pressure. Next, to build and reinforce some motor control of the jaw to reduce those unwanted jaw motions, especially that excessive protrusion or lateral deviation that we see with talking or chewing, we use the tongue's rest position and keep it there to control the rotation that occurs with the TMJ through repeated opening and closing motions. Rhythmic stabilization are gentle jaw contractions that are done without movement to promote muscular relaxation via reciprocal inhibition, which promotes an improved resting position of the jaw through proprioceptive input. The remaining exercises have to do with posturing the upper quadrant. To reduce tension in the cervical musculature, upper cervical flexion with lower cervical extension is encouraged, as well as shoulder girdle retraction and depression. To further help center the jaw and craniovertebral region, tucking the chin to distract the upper neck while lacing the fingers behind the neck to ensure the rest of the neck stays still is a nice exercise to reset posture as well. The feedback I get from my clients is that these exercises are not terribly difficult to do, but they are relieving as well as they draw attention to the areas and patterns of movement they weren't aware of. The biggest challenge they find with these exercises is just the frequency. They don't take long to do, but carving out time in anyone's day can be difficult. However, if our patients want to change, they have to do something different. I remind them that we all have the same amount of minutes, and although it may initially seem impossible to fit something else in, we can prioritize and schedule time for the things that matter. And if investing time now can improve their quality of life later, there is a huge motivating force to make it happen. Aerobic training is absolutely essential for myofascial TMD, and it has an important place for effective pain management and overall health and capacity to heal. Encouraging and supporting our patients to accumulate 150 minutes of moderate to vigorous cardiovascular exercise weekly is the foundation of any exercise program. In order to maximize the effect of Rockaboto's program, there may be the need for some remedial exercise to be able to do his exercises well. This often comprises shoulder girdle and cervical strengthening and breath training. On an individual basis, we take the time as physios to properly dose on a case-by-case basis to provide sufficiently aggressive techniques to load and allow remodeling of the TMJ, but also to avoid unnecessary symptom provocation. So, as healthcare providers that have the respect of our patients, it's our duty to inconspicuously support and encourage wellness via a healthy, active lifestyle, good diet, and stress management. Flossing, brushing, and routine follow-ups have their best effect when it is supported by living in a healthy way. Consider implementing outcome measures with your patients on their initial visit to get an idea of their personality profile. As mentioned, I find the DAS and CSI to be very revealing for those people that are so great at putting on that brave, stoic face. Early identification and better yet prevention is the best way to manage TMD. Getting to know your patient and putting that in the context of your objective exam is ultimately what is going to allow you to make the best clinical decisions, in addition to collaborating with your patient's allied health team. If you do feel like your patient would benefit from physiotherapy, we are primary access providers, so patients can self-refer themselves. However, some extended health benefits do require a script from either their doctor, dentist, or oral health specialist for eligibility. I love keeping the lines of communication open with all of the team members. If you're sending someone over to physio, providing a quick note with either your concerns or goals you would like to have worked on facilitates great collaboration. I like to send brief assessment and progress notes back to the oral health team to keep you guys in the loop of where we are at. So on that note, I hope that this was helpful in understanding what physios are looking for and how they can help with TMD care. A big thank you to Dr. Abraham for asking me to share my perspective, and to Dr. Rabaru and Jen Mayhew for their input on what content would be helpful as well. Stay well, everyone, and keep moving. Until next time, take care.
Wow, that was a very, very informative lecture from Corey. Again, I just really want to reiterate of how much knowledge there is in this field that I think is beyond a lot of our training that we've all had at various levels of our career. And, I think this really just highlights a really important collaborative approach where we could really help our patients in just so many different ways. And I think Corey does just a great job of doing that. So again, all of her contact information is in the event registration, as well as we have it here in the chat that's on the side. We're going to continue to answer, but for the most part, we are all set for today. I, again, just wanted to thank you guys for taking time out of your day to join us. If you have any further questions or if, things weren't answered the way you were hoping or need some more information, please feel to reach out to Corey or to myself, and we'd be more than happy to help you. We definitely have more webinars coming up, and we'll have our survey coming out again. And please, any topics that you guys feel would be relevant to you, or that's timely, or something that you'd want to hear, just please feel free to let us know, and we'd love to get everything together. Thanks, guys, again so much. Have a great day, and we'll talk to you soon.